video, I'm going to talk about what to do with a shoulder eval. If you get someone in here that says shoulder eval is on your schedule, and the script says eval and treat shoulder pain, right? What do? So the first thing you need to do is ask questions, right? Ask questions. Now, I already know I went through that before in another video in terms of what kind of questions to ask, but the mechanism of injury is really, really important in terms of how you're going to move forward with your testing. So if you think about your shoulder, there's pretty much like, if you're just talking about your shoulder, there's pretty much three things, right? Three things that you want to think about. Is it a rotator cuff problem, right? So is it a tendon problem? Is it a labrum problem, right? Or the catch-all phrase is an impingement, right? Which just means that things are not moving well, right? So when you get someone with shoulder pain, you've got to rule in and rule out problems before you can even start to treat them, right? So after you ask your questions, you need to decide, do I think this is a rotator cuff problem? Do I think this is a labrum problem? Or do I think this is an impingement problem?
What about the
scapula? Scapular movement can cause impingement issues. So all of that would affect scapular motion, right?
What if
so
they don't have any of those three? They just have a scapula that's limiting them. Like they don't have an impingement or anything. They're just winging. Because some people just wing. They don't have any impingements. They don't necessarily.
They don't have any pain.
Yeah.
So why are they coming?
Limitations in movement, right?
Limitations in movement.
Or in back movement.
Or back, yeah.
Right?
But they're usually coming to you for some kind of dysfunction.
Yeah, the limitation in movement, but not
limitations.
It's not a labrum thing. It's not a cuff tear, right? It's just like
if it's
winging and like.
Well, so then you're talking about just generalized stiffness, potentially? So there's like no pain. Yeah, you can, yeah, so you would look at motion for that, but you still have to rule out like, why are they stiff? Why do they have a mechanical problem somewhere?
Yeah, but it's just the alternative is not any of those things.
So then you would rule all those out.
Yeah.
Yeah, and then it'd just be like stiffness. But at least you rule it out. But there's three major things, I would think, when it comes to that. So if we look at rotator cuff, let's say, because you can have scapular motion, like poor scapular movement, due to rotator cuff tears, because now you have an imbalance. You could have poor scapular motion because of a labrum tear, and it can have an imbalance. Labrum tears are kind of pretty specific to an injury. Because of the nature of what the labrum is, that connective tissue that builds out the rim of the glenoid. Now you can have wear and tear of it, but majority of the time you're listening to questions of mechanism of injury. I fell backwards. I fell on my arm, in a certain way that jams into the shoulder. Usually a rotator cuff tear, you can have mechanism of injury of fall too. I fell and I was trying to catch myself and I caught myself, Yeah, fractures, yeah. So if they came into you, somebody else would have ruled out fracture. Someone like fracture, someone else would have ruled that out for you. The doctor would have ruled that out for you. So you don't have to rule anything out. I'm talking about like, if someone comes to you with a vague diagnosis, you'd have to try to rule it out yourself. Versus fracture, you wouldn't see it. Doctor would tell you, like, I saw it on x-ray, it's fractured. So then you'd already know what to do with a fracture. Okay, well, I'm allowed to do active, I'm allowed to do passive, based on the weeks that has passed, right?
What if we question like the doctors? I think just like with hands, sometimes we're like, oh, it's
yes.
getting better. Then we have to have them take a second MRI. We're like, oh, it's actually a fracture. We didn't see before.
Yeah. So you could still rule it in and rule it out. So, but the diagnosis already came to you as a fracture. So let's say you have a fracture, then you'd have to go how many weeks, And you'd say, okay, well, is that fracture healing? You would press on the bone. Like when you press on a bone, when you press on the site of the bone where it's broken, if it's not fully healed, they'll have pain. The difficulty in the shoulder is if they have a lot of muscular pain, you can't differentiate it. So in that test, you can't rule in or rule out. You'd have to rely on someone telling you it's a fracture. And then you would go and be like, okay, I'm going to test other things. I'm going to test, was there a rotator cuff type of issue? Could there potentially be a labrum type of issue? Or are they fractured? Now they have pain because they have impingement because something was fractured. Now nothing is moving well. Scapular's not moving well to the humerus, right? So if you get an eval and treat and it just says shoulder pain, right? So let's go through a scenario. I think that would be the best case, right? So if they came in, eval and treat, and I have shoulder pain, what's the scenario? Like, what would you do first, right? You'd ask the questions, and your brain would start to think. You know, could it be a tendon problem? Could it be a deeper, you know, connective tissue labrum problem? Is it just an imbalance of things not moving well? So what do you do next? You look at range. So you have to look at like pain level to determine which tests to do. You'd look at pain. What would you do? And then you look at motion, right? Now in range of motion, you have active range of motion, and then you'd have passive range of motion, right? That you want to take a look at. You'd have to see those things first before you pick any special tests. Right? Because you're not going to push on somebody if they have a ton of pain, because then you won't be able to diagnose, you won't be able to differentiate, well, is it that test or just they're just so painful? So if someone comes in, they have shoulder pain, we can first go on, how should I do this? Should I go on, what's the easiest way you think? Because there's a lot of things that can happen. So let's think about how, like what scenario it could be. All right, let's say, you know what we get a lot here is we get a lot of people here who come in and they have great range of motion, right? And they have pain, right? So let's go and say, I have somebody who, they come in and they have, like, my shoulder hurts. I heard it months ago, possibly years ago, and nothing I do helps me to get it better. Like it hurts all the time, right? Hurts all the time, but when we ask, what are you not able to do? Oh no, I can move my arm. I can reach up. I can, they'll say that they can do everything. There's usually one thing that they can't do. And let's say I can do everything, but every time I work out, it starts to hurt me, right? So then what would we do next, right? What would we do next to rule it out?
Figure out what motion in particular is the one that's causing them.
Right. So would you do active motion?
Both, but
You do active motion and then you do pass. So I normally have them thumbs up, elbow straight. I always do thumbs up, elbow straight, just because it's a neutral position for forward flexion, right? So one of the things that you would see, and you want to tell them to keep their elbow straight and their arm as close to their ear as possible. If they can't do that, if they come up and then you'll see one arm wings out like this, then that means they're stiff. There's some tightness somewhere. So if they're tight somewhere in your mind, you would say they're tight, right? Something is stopping them from moving the way they're supposed to. It's just things that you have to keep in your brain, right, before you test. So they wing out, that's an observation. And then you can look behind and you would see, like when they do it, look at their scapular motion. So if their one scapular motion is not moving with the other one, then you'd say, okay, something's going on with their scapular motion. And we can go into tipping, winging, and abduction later. right? But here we're just looking, we're starting to think through like, what tests do we do, right? So if they go and they say, what do they say? Like every time I bring my arm up like that, it hurts, right? And then every time I bring my hand, so then you can have them do external rotation, you can have them do functional external rotation, you can have them do functional internal rotation. And in the internal rotation, as well as just about anything else, you're looking for patterns of movements that are abnormal. So anyone who cannot bring their arms in behind their back, they will tuck and roll. They'll tuck their pelvis, and then they'll roll their shoulder blades forward in order to get into that position. So then you already know now too that they have some tightness. They have some anterior tightness. Internal rotation is also inferior glide. Their humerus has, almost all motions have to have some inferior glide. So in order to be able to go up, your humeral head has to dip down in order to clear the acromion, right? And your scapula has to come up slightly and move out. It has to rotate, right? So that's the only way it can clear. So if they have pain, then you know, okay, there's an imbalance to the capsule itself in terms of there's certain tightnesses somewhere. Now you just have to figure out where, right? So if they come in with that type of shoulder pain, that they can move like that, I'm going to try and rule out any kind of rotator cuff types of issues, right? So if they, so most of the time, if they can come up, you don't have to do empty can. So usually empty can is like internal rotation, is it empty can? Yeah, internal rotation like this and scaption. If they have pain, then they're hurting their infraspinatus. So I'll go over empty can anyway. So empty can, it tests your supraspinatus. So if you go into internal rotation and then you lift your arm up, not in forward flexion, not in abduction, but kind of in that scaption, and they can't do it, or they have symptoms with it, then it's something's going on with your infraspinatus. If they come in and they say, I can't lift my arm up, but if I lift it up like this, I can keep it there. But then they have to help themselves down. That is a rotator cuff tear as well. Another thing for testing rotator cuff is external rotation. So you would want to see, can they externally rotate? And if they can, you'd see like how much do they have, how much external rotation they have. If they don't have a lot of external rotation because there's stiffness, then you would give some, you'd apply resistance. So resisted external rotation, and you would feel if they can give you resisted external rotation. If they can give you resisted external rotation, then that means that they don't have a full rotator cuff tear. The only thing that you could see clinically to rule out is if they have a full rotator cuff tear, right? If they have partial rotator cuff tears, all you're doing is getting symptomology from it. So if they have less than a 50% tear of their rotator cuff, they can be very successful in therapy. If it's greater than a 50% rotator cuff tear, then usually if they've gone to the doctor would recommend surgery. Now, some people can try therapy and be very successful, but there depends on their level of activity that they want to get back to. So if they're like a little bit older, they're very sedentary, then they don't necessarily need to go rushing to surgery. But if they're a young person and they do a lot of heavy work, they do a lot of heavy overwork, then the majority of the time doctor's going to recommend surgery, right? So you've got two tests. You've got empty can to test supraspinatus. Oh, I did? No, it's supraspinatus for empty can. And then when you're testing external rotation is more infraspinatus teres minor for external rotation. But that's what you'd be testing for. So you test for external rotation range, and then you test for resisted external rotation, and that's going to give you your rotator cuff. You're going to rule in or rule out.
Eccentric. Rotator cuff too, you said, right?
Well, with rotator cuff, so if you put them up and then they can't bring their arm down, that's usually very indicative. But that's usually the story of, oh, I can't lift my arm up, but if I help it, then I can keep it there. And then when I come down, it's a drop arm test. That's called the drop arm test. I forgot the name of that stupid test. So let me write. So you have the empty can, right? So you have the drop arm test, right? And then you have
active external rotation.
Resisted. Yeah, resisted. It's resisted external rotation. I just look for external rotation first to see if I can even give that. If they cannot go at all, then what are you going to resist here? Like they won't be able to resist at all, you know? So resisted external rotation. So just like when I look at forward flexion and stuff like that, the same thing with external. I'm just looking for external rotation first, and then I'll do the so those 3 tests are for rotator cuff, right? So you're just looking for rotator cuff types of issues. Good?
Yep.
Did that help you? A lot, okay.
Hey therapy friends, it's Huang here. Thanks again for watching my video. And if you like videos like this that can help you just crush it in the hand therapy world as an occupational therapist, then hit the subscribe button and enjoy the video. Thanks again for watching.